Good morning. I'm Dr. Warner, and today on our webinar series, which we do just to do it, I'm going to talk about hormones and menopause, and specifically as it relates to the musculoskeletal system. As some of you may know, I'm an orthopedic surgeon in Baton Rouge, but I'm very interested in health and wellness. And I have patients asking me about hormones all the time. And probably worse, I have patients that don't ask me about hormones because they don't think that it matters in terms of the musculoskeletal system. But I am here to tell you otherwise, and to tell you that hormones, particularly for women in menopause, are massively important in how you feel. And we're just going to discuss the ins and outs of that briefly. Obviously, I'm not an endocrinologist and I'm not an OBGYN. This is my perspective based on all the research I've done over the years. And certainly each topic in this talk could have its own talk, but I'm going to try to keep it broad. All right. Why should an orthopedic surgeon care about hormones? I'm sure many of you out there see orthopedic surgeons and they probably don't care about hormones, but I do. So we're going to talk about estrogen, progesterone, a little bit about testosterone, not really, and how it impacts your body, meaning your tendons, your ligaments, your brain, your bones, your muscle, all the things that you really care about as you're aging. So if you don't want stiff tendons, you don't want weak muscle, you don't want weak bones, you don't want hip fractures, you don't want joint pains, you don't want aching, and then you don't want all the neurologic complications of menopause, such as hot flashes, nausea, mood swings, etc., then yeah, you need to care about hormones. I have found that people that have a good balance of their hormones as they go into perimenopause and then menopause and beyond seem to feel better than the people that don't. And I've also conversely seen all my patients on aromatase inhibitors for their breast cancer, the ones that have had breast cancer and had it treated, and now are on things like tamoxifen or whatever, they tend to have more body pain than my other patients. So there's something to this, and we're going to dive into it. Okay. So we're just going to have a brief introduction to the hormones of the musculoskeletal system, the key hormones, the hormonal effects on connective tissues, which is what I'm interested in, fascia, ligaments, tendons, muscle, bone. And then what does happen when you're estrogen deficient, which is the definition of menopause, really. And then what are the benefits of estrogen on your bone, your muscle, and your brain? Should you want to replace the deficient levels? And then of course, the elephant in the room, the Women's Health Initiative study. We're going to talk about the findings and the controversies to give you a better understanding. And honestly, it's so confusing. It's really hard to have a good understanding of that. And then estrogen and cardiovascular disease, okay? But this little circle diagram shows you how estrogen deficiency affects everything. You get telomere attrition, which means your longevity is compromised, mitochondrial dysfunction, which means everything's just going to fall apart. Genomic instability, stem cell exhaustion, your microbiome gets disturbed, which means your gut gets affected, you have more inflammation, just goes on and on and on. So being estrogen deficient is not a good way to be, and we are going to discuss the ins and outs of that. So there are different types of estrogen, just really quickly. 17-beta estradiol, E2 is probably the more common one. Then we have estrone and we have estriol. So we have E1, E2, E3, and all of these are derived from cholesterol, okay? So cholesterol is transferred from the cytosol to the mitochondrial membrane, meaning from the fluid inside of a cell to the mitochondria. And then at that point, the number of carbon molecules in the cholesterol molecule is depleted from 27 to 18 through a series of enzymatic chemical transformations. And then they get aromatized. This is why you have aromatase inhibitors. So aromatase is an enzyme that then converts the final molecule here into things like testosterone and estrogen. Now, if you have polymorphisms or single base pair changes in your genes for your steroidogenic, that's a terrible word, steroidogenic enzymes, that may, we think, account for different levels of E1, E2, and E3 in different women, because obviously everybody's different, even though all of the insurance companies and the FDA like to look at us as a population, and it must work for the population in order for it to be covered and approved. Real medicine is precision medicine. Everybody's different. Everybody needs to be looked at differently, and everybody needs to be measured, checked, and then treated based on their levels of different things, such as, for instance, Estrogen. So basically, the important point for you is cholesterol to precursors, aromatized estrogen. So aromatase activity is found really in multiple tissues, very much found in excess fat. So the bigger you are, the more energy excess you carry around with you. In the form of adipose tissue, the more likely you are to be converting molecules that started as cholesterol into estrogen. So you're going to have elevated levels of these things. The Leydig cells of the testes produce estrogen, and then nervous tissue can have, produce aromatase. And then nervous tissue can also have this. What does that mean? If aromatase is found in all of these molecules, it must mean that estrogen activity is important in those tissues. So you wouldn't have the enzyme that is necessary to convert the testosterone to estrogen in tissue unless the body felt like it needed it to be there to achieve some function. For postmenopausal women, most of our estradiol that is left around or is still in the body found after menopause is formed by extragonadal, that should not say estragonadal, extragonadal conversion of testosterone, meaning testosterone is in the system somehow, and then outside of the ovaries, it is converted by aromatase into estrogen. So again, cholesterol to testosterone, then hit by aromatase, that becomes estrogen. So your estrogens are generally found in the bloodstream, bound to a protein called sex hormone binding globulin, or they're found bound to another protein called albumin. Otherwise, they're free. So you can check your estrogen levels, but a real panel will break it down by what's bound to the sex hormone binding globulin and what is actually free. Because those levels matter in terms of trying to modify or change things by treatment. The estrogens are degraded in the system and then they're transferred into bile. And if you don't remember what bile is what's spit out by your gallbladder to kind of help the liver get rid of things and recycle products. So bile will go into the gut and it'll either be excreted as feces or things will be reabsorbed from the bile and recycled. That's called the enterohepatic circulation. So the liver and the gallbladder will spit out the substances in bile into the gut, and then it comes right back in. It gets recycled through the enterocytes in the intestine, or the intestinal lining cells will suck these things back in and recycle them as necessary. Okay, so degraded, put into bile, reabsorbed, enterohepatic circulation. At that point, these things can be chemically modified even more. So they're either hydroxylated or methylated. So a methyl group is added or a hydrogen group is added. And then you get things like catechols and methylated estrogens. Some of those are considered carcinogenic. So although we always worry about estrogen, sometimes it's the body's own breakdown or metabolites of estrogen that are carcinogenic. Because that's the big monkey or the big elephant in the room that we're going to talk about later with the world WHI, the cancer risk of estrogen, right? But I just wanted you to know this is a pretty complicated pathway from cholesterol to use to reuse, recycling, and then the metabolites can sometimes be helpful, sometimes be harmful. So you're going to find estrogen receptors in many, many tissues. So it's one thing to have estrogen floating around or testosterone or whatever. Those substances almost become irrelevant if they don't have something to connect to make something happen. In other words, these are just the keys. Estrogen's just the key floating around, right? But until it finds a lock to unlock or lock, it's really just a key doing absolutely nothing. So you need to have receptors, which really the receptors become very important as we talk about the musculoskeletal system and also the brain. So males that were found without estrogen receptors were actually found to be very, very osteoporotic and have reduced fertility. So estrogen receptors are even found in men and are very, very important to function of their physiology and their bodies. So if you don't have estrogen receptors, you are definitely going to have brittle, terrible, tragic bone, more at risk of fractures, more at risk of death. And then, of course, the same thing's going to happen to all of your other connective tissues like your cartilage, your ligament, your bone, your muscle. And then in men without estrogen receptors, they actually had reduced fertility. The estrogen receptor beta, there's an alpha and a beta receptor found in the granulosa cells of the developing spermatids. found in the kidney, found in the intestine, found in the lung, found in bone marrow and bone, found in the brain for sure, found in endothelial cells, which are your blood vessel linings, so very important for cardiovascular health, and then found in the prostate. The alpha receptors are found in the endometrium, breast cancer cells, and the ovarian strata, which just means, what makes up the ovary. So basically they're found all over. This little chart just shows you the density of the alpha and beta cells found throughout different areas. And then actually, more importantly, the ligands that will attach to those. So again, the ligand is the key. The receptor is the lock. So the ligand includes things like tamoxifen, raloxifene, all of the estradiols, but also things like genistein and diadzine, which are found in different natural substances. So these are the phytoestrogens you're hearing about. Now, one thing I didn't put in this talk, which probably deserves its own talk, are the estrogen mimicking plastics that are in the environment now. I did not put that in this talk because it's super duper complex. So if you have questions about that, we'll probably do another talk later. But so now you know there's a lot of estrogen floating around, but it's irrelevant unless you have receptors. But now you know there's receptors everywhere in your body, particularly the musculoskeletal system. So what are SERMs? These are selective estrogen receptor modifiers. These are developed in the hopes that potentially you could have a drug that would latch on to the receptor of estrogen found in tissues that you wanted estrogen to give a response to, but not where you didn't want it to act. So it's selective. So it would selectively go to maybe the alpha estrogen receptors in bone tissue or something like that, but it would skip over the estrogen receptors in the kidney. I'm just making that up. So raloxifene is one of these. It's called Avista is the brand name. This is an agonist, meaning it turns on the lock, like it opens the lock. So it's an agonist action of estrogen desired in bone. So this drug is meant to turn on the estrogen receptors in bone to maintain bone mineral density, but not to do bad things to you. In other words, not hopefully increase risk of any disease or problem. It's also thought to agonize estrogen in the cardiovascular system in a desired way, a beneficial way in the brain to maintain function. So it's an agonist on bone, and it's also thought to help with your serum lipid levels. It's an antagonist of the receptors in breast tissue and endometrial tissue. So hopefully that makes sense. So this drug was meant to turn on or open the locks in the bone, brain, cardiovascular, but to turn it off in the breast and the endometrium. So unfortunately, there's some thought that it's also an antagonist in the brain receptors. That is somewhat confusing and unclear in terms of the literature that I saw. But because of that, think about this. If it's antagonist to estrogen in the brain, then it's going to actually increase vasomotor symptoms. What are vasomotor symptoms? Hot flashes, night sweats, things like that. Remember, your fever center is the hypothalamus, and that is found in the brain. That is where your body temperature is controlled, is in the hypothalamus. So anything that is going to adversely affect temperature control in the brain is going to give you those hot flash symptoms. So raloxifene may do that. That said, it's a great drug for helping your bone health. So all menopause is, and I'll give you the technical definition later, but effectively you're estrogen deficient. So you have fewer estrogen effects. So this is thought to, or was thought to, cause breast cancer and endometrial cancer, and meaning estrogen. It's also thought to stimulate blood flow, water retention, and growth of your sex organs, okay? In the liver, it's thought to increase the number of your lipoprotein receptors. So if you have more receptors that capture lipoproteins, you have lower LDL in your blood. That's all the statins do, is they increase the number of receptors for LDL, and they suck LDL out of the blood, drop the LDL, so you have less risk of atherosclerosis. So estrogen is thought to do the same thing. Unfortunately, estrogen can also increase your potential for coagulation. So a lot of people on hormone replacement therapy are at risk of blood clots with surgery and things like that. In the GI tract, it's thought to protect against colon cancer, while at the same time, it's thought to cause breast cancer and endometrial cancer. And in the skin, it's thought to increase the turgor, or the hydrostatic pressure, and the collagen production. So if you have estrogen deficient skin, you'll have deeper and more wrinkles, right? And they'll be less elastic. So there are actually some drugs out now, topical ones that can increase estrogen levels in the skin to counteract the menopausal effects on skin, which decrease collagen, which increase wrinkles. Collagen, again, being massively important in the musculoskeletal system. So the same thing that's causing wrinkles and whatnot on the face, the same sort of process is happening in all of your connective tissues, your muscle, your bone, your ligaments, and your tendons. So what is menopause technically? The permanent cessation of menopause or menstruation, the permanent cessation of menstruation for about a year due to ovarian failure. The average age is about 51. Globally, I think it's 49. Perimenopause is the time around that time period where you actually don't menstruate for a full 12 months in a row consistently. That's when you have fluctuating hormones. This can last anywhere from 4 to 10, even 15 years, where your body's just trying to figure it out. You're not really in menopause, but you're not really menstruating. So it's like you're in between. You're in perimenopause. True menopause is 12 months without a period. So when you have your last regular period, okay, 12 months later, assuming you don't have one, you're in menopause. That's your technical definition. Basically, all it means is you have lower levels of estrogen and progesterone. Also, though, your testosterone levels change. They decline naturally in men and women, but men will always have more testosterone than women, generally speaking. The FSH, or the follicular stimulating hormone levels in women, rise significantly with menopause. And you can see that on this chart. The black line is the estrogen levels dropping. And as you hit that blue, the darker blue bar, that's menopause. They drop precipitously and get very low relative to where they were before. The opposite happens with FSH. So one way to know if you're in menopause is to measure your FSH to estrogen ratio, assuming that you're not on HRT or any other complicating medication that would change these levels. The brain is telling the ovaries to make more estrogen. That's why you have more FSH. But the ovaries are not responding. So the brain has not really turned itself off in terms of its feedback functionality. So it's still feeding back saying, make more estrogen, I need it, I need it, I need it. Thus the high FSH, but the ovaries, the production, the factory for most of your estrogen are shut off. It's not happening. So consistently high FSH levels is a good sign you're in menopause. Now, I made this chart for you to show you normal levels of all hormones by age. And I tried to put it in the same unit, but that did not happen. So it's not in the same unit. So it looks wildly different. But if you put estradiol, progesterone, testosterone, and FSH in the same unit or unit of measurement, see here we have picograms, nanograms, and micro international units. So these are all different. You would find that men and women don't vary that much, which means what matters? The receptors and the receptor density, right? So your levels as a woman of estradiol, when you're 40, you're going to be 30 to 400, huge normal range. Speaking to what I said before about precision medicine, your normal might be 400, but my normal might be 30. Now, if you're looking at population statistics, how do you know? You don't. So just know that the normals are all over the place. But by 50, it's less than 30. So 30 to 400 at age 40, less than 30 by the time you're 50, okay? And men at 50, 10 to 40. What does that mean? That a 50-year-old man might have more estradiol than a 50-year-old woman based on the normal ranges. And then, of course, with menopause, it drops precipitously, as I just showed you. So next slide. So what are your symptoms of perimenopause? Remember, that's a 4 to 10 year time period during which everything is fluctuating and you're not really in true menopause by the technical definition. They can't see the chart? Oh, I'm sorry. Yeah, sorry. I just found out the chart's too little. All it's showing you is this. You're going to have irregular periods, hot flashes, night sweats, sleep disturbances. Insomnia is one of the biggest problems. Mood swings, anxiety, vaginal dryness, changes in the libido. About 1/4 of women in the perimenopausal zone say that their symptoms are debilitating and that their quality of life is very, very low. That's how bad these symptoms are. And all it is an estrogen deficiency. There is no age on this chart. It's the percent of women experiencing the symptoms. So memory problems, almost 70% experience it. 60% have difficulty sleeping. 60% have a bad mood or anxiety. 60% have joint pain and stiffness. Reduced sex drive is 55%, night sweats 50%, so on and so forth. Interestingly, recurrent urinary tract infections is also a symptom. It's less than 10%, probably much higher in the nursing home population. So one way to manage this is vaginally applied estrogen, and the rate and intensity of urinary tract infections can go down. Why? Because there are estrogen receptors in the mucosal lining of the genitourinary tract. So if the estrogen receptors aren't getting the key in the lock, they're not going to send the proper signals to the cells to do what they're supposed to do, and you get more urinary tract infections. So what are your musculoskeletal symptoms? Well, I just told you 60% of people get joint pain, aching, stiffness. Sadly, also a change in bone density. Now, previous talks I've told you, bone density and bone health is strongly correlated with cognitive abilities. So the more osteoporotic you are, the more likely you are to have cognitive decline. So perimenopausal and menopausal symptoms affect about 80% of women, or at least the women that have been surveyed for these various studies. Who knows what the real number is, but let's just go with 8 out of 10 women have menopausal symptoms from their estrogen deficiency, and they have a reduced quality of life. So this is why you're wearing knee braces. This is why you're getting HA injections. This is why you're going to get massages, why you got to go to physical therapy, and, you know, God forbid, why you have to have surgery. All of this, a lot of it can be linked to the estrogen receptor density in these tissues and the lack of the estrogen going into the receptor to turn them on to do the proper function for the musculoskeletal system. What is the musculoskeletal system? If you're wondering, joints, bones, muscles, tendons, ligaments, cartilage, basically what lets you move and what protects organs and protects the brain and keeps us out of trouble, okay? It allows you the ability to exist in a gravitational field in an upright position, and up to 80% of women will develop issues in these tissues. So they're gonna have pain, weakness, loss of muscle, fractures, loss of bone density, sarcopenia, which is the scourge of aging, I think. All of this, or a lot of this, can be linked to the estrogen deficient state. So estrogen's role, again, remember, generally speaking, it's produced by the ovaries until they shut down. E1, E2, estrone and estradiol. They do regulate reproduction, obviously, but they are strongly regulating bone health and cardiovascular function. This diagram is showing an electron micrograph of an estrogen receptor and then how it affects the nucleus. So it'll actually go in and tell genes what to do, like turn them on or turn them off. Estrogen is very important in maintaining the integrity of your connective tissue. In other words, the structure of the cells, the relative amount of elasticity in the tissue versus stiffness, the communication between cells, the extracellular matrix, which is probably the most important part of connective tissue. And then estrogen is also known to reduce inflammation in all of these tissues. So from prior talks, you know that I believe a lot of our problems in the human body stem from too much low-grade inflammation, or the innate and adaptive immune systems kind of doing things to us that they should not be doing rather than attacking pathogens. And then too much oxidative stress, which of course is electron or free radical damage of tissues. Estrogen seems to reduce the effects of inflammation and oxidative stress. So when you pull the estrogen, you're going to have more of these effects. So a lot of the patients I see in my clinic who are middle-aged women with these issues, if they're not on HRT and they're GYN, or they don't want to be on it for some reason, it's even more important to control the inflammation, the oxidative stress. So it's more important that they take natural substances like the Joint Health Multi, and also omega-3s, and also tart cherry extract, things like that, to try to really control and tamp down this inflammation because they're in an estrogen deficient state. So estrogen can increase the collagen content, not just of your skin, which is of course primarily what a lot of women care about, but also the tendons, ligaments, and the bone. So not just what's facing the world, but also everything inside of you, which allows you to function in this world that has gravity and surfaces that you need to get over and things you have to pick up and kids you need to play with and tasks you need to do and work that must be done. You cannot do that without a functioning musculoskeletal system, which requires the right keys for the locks, or you need to have the right hormones. It enhances muscle mass and strength. So as you lose estrogen, you're going to naturally lose muscle mass. We lose about 8% a decade or 1 to 3% a year. And the only way to fight back is with exercise, of course, which is by far the best treatment for all of this, just so you know. Exercise, the best treatment for brain health, musculoskeletal health, etc. But let's assume that you are exercising and doing what you need to do. You're still going to lose muscle mass if you have an estrogen deficient state. Estrogen also promotes chondrogenesis. What is that? Chondro is cartilage, genesis is making of, so the making of cartilage. It supports tissue elasticity, or the better term will probably be that it regulates tissue elasticity and then supports tissue repair. So estrogen will actually increase the number of, for instance, satellite cells, which are muscle stem cells, and help with the repair and recovery of muscle damage that happens during the day. So estrogen is hugely important for the connective tissue system or the musculoskeletal system, although for years it was thought not to be. Progesterone, another hormone that we talk about a lot, and some of you out there might be on HRT, you might be on single molecule or estrogen only, or you might be on a combo therapy, which would be estrogen with progesterone typically. This also declines in the perimenopausal period. Its function normally is to prepare the uterine lining to accept an embryo to grow a baby. So when it doesn't get that baby, or when a fertilized egg doesn't happen, the lining sheds, thus menstruation. So progesterone is integral to that functionality, but it also modifies the effects of estrogen on tissue. And we think it might counteract the effects of estrogen on muscle protein synthesis. So it is very important to have the right balance. And it will also affect your tendon stiffness, the ability of the tendons to heal. And we think it may be protective against so-called overuse injuries. So for like athletes that are running around doing a lot, hormones play a large role in how they recover and also in their injury rates. And this is just a picture of starting at the microscopic level of tropocollagen, which remember is 3 braided groupings of amino acids lined up together, with every third position being glycine. This is why I often recommend glycine to people, especially menopausal women with aches and pains. You start with a triple helix of the tropocollagen. That goes into a microfibril, that goes into a subfibril, that goes into a fibril, then a fascicle, then a tendon. So it's just like building the braids out until you get the structure you want. So testosterone in women actually declines as well, and that's an important feature of menopause. So it declines in both men and women over time, and this shows you, but it really declines in women as they hit menopause. So that midpoint range where it says low in age on this chart is between 40 and 50. 50, 51 being the average age of menopause, that's when it really drops down. So it's less than 20 nanograms per deciliter generally. Normally, women will have 10% of the level of male levels of testosterone, but again, the receptor density is even more important, but it's still present and it's still important for women. It is also produced by ovaries and the adrenal glands. Testosterone has anabolic or building effects on muscle and bone. So if you have really low testosterone levels as a female, low for a woman, that is, one way to counteract the loss of muscle and a few other symptoms is to potentially replenish your testosterone back to a normal woman's level. Again, realizing that the normal range is all over the place. Testosterone is also known to strengthen the connective tissues. A lot of people nowadays will give people testosterone or growth hormone while they're healing from musculoskeletal surgery. That's sort of in the advanced precision medicine, anti-aging world. In normal medical practice, that doesn't happen, mostly because insurance won't cover it. It's usually off-label use, meaning the FDA doesn't have an approved use for testosterone to assist with connective tissue healing. But I'm just telling you, it happens, it's done, and it does seem to have really good results. It'll stimulate chondrogenic differentiation, meaning it'll help you make more cartilage. And then low levels of testosterone are linked to weakness and hypermobility. So weak muscles often cause joints to be looser than they need to be or more prone to injury. So one way you can help your joints out is with strength, especially the muscles that cross joints. So like the quadriceps, the gastrocnemius complex, they cross the knee joint. So do the hamstrings. So if you can strengthen those muscle groups, your joints are stiffer, mostly because of the dynamic action of the muscle. So as you get weaker, your joints are going to be more prone to injury and pain. So testosterone does play an important role, and is something women, even postmenopausal women, should consider or think about. DHEA, you may or may not have heard of this. It's dehydroepiandrosterone. That's why everybody says DHEA, because that is a way too long to say. This is one of the molecules in the metabolic pathway of creating testosterone and estrogen. It is a precursor, meaning a molecule before. It is thought to support muscle maintenance or muscle growth and recovery, but the literature is kind of equivocal. It'll go either way. It may actually increase the fat-free mass in women, which we don't want. And an imbalance in DHEA can amplify any issues with estrogen and testosterone. Why? This is a precursor molecule. So if you already have too much testosterone, let's say, and then you're producing DHEA and it converts into testosterone, it's just going to make that problem worse, thus amplification. It is thought to help with bone tissue, which means it must amplify the effects of estrogen on bone, but it is not a primary treatment for bone health. Okay, just so you know, you can't just take DHEA and think that you don't have to be on an osteoporotic drug if you have osteoporosis, or you can't just take DHEA and think all your problems are solved. I know it's out there and it's kind of big and trendy in some places. The place I've seen DHEA work well is for people with chronic inflammation of the spine after surgery, like arachnoiditis. It does seem to help with pain control there, but it is not really a primary drug for any of these indications, but it is in the pathway of estrogen and testosterone. Okay, I put this slide here just to show you the very complicated way that cholesterol becomes hormones, and I circled the important molecules for you. So you start with cholesterol, top left, or DHEAs, which are top right. They pass through various enzymatic transformations, will become testosterone, and then it gets aromatized and you get estrogen. Also in the same pathway, you're going to make your corticosteroids, okay? So like you have your anabolic steroids, which build things, and your corticosteroids, which induce more glucose formation, induce inflammation, the stress response, or stress or relaxation response, or the sympathetic versus parasympathetic. So all the same pathway starting from cholesterols. Estrogen deficiency is when your estrogen levels are less than 10% of normal, which is postmenopausal. Okay, so after menopause, you will have lifelong estrogen deficiency unless you do something about it. So just wanted to emphasize that, lifelong estrogen deficiency. And I already told you how important it is to the musculoskeletal system. So my opinion for musculoskeletal health or orthopedic health, you really need to strongly consider HRT, obviously after you talk to your OBGYN and or your endocrinologist. But just think of how it even plays into skin wound healing, which is why I put this slide here. So estrogen is so important. It even helps you heal wounds better, meaning it must have an effect on the immune system, obviously. But if you reduce chronic low-grade inflammation and oxidative stress, the immune system works better, and then you could even heal things better and faster and quicker. So again, speaking to connective tissue health. So to me, estrogen deficiency lifelong isn't fair, and I don't think we should have to suffer all of these problems just because of menopause. Excuse me. So as an orthopedic surgeon, one of the most important tissues to me is bone. And as a human, you need to be worried about bone because, again, I told you there's a strong correlation, if not causation, relationship between good bone health and mental function. Your bones have to be strong for you to be strong. Your bones have to be strong for you to have good muscle function and to respond to your environment. If you're estrogen deficient, you are having accelerated bone resorption, meaning that your body is depleting your bone of the mineralization that it requires to remain strong. So it becomes brittle, it becomes more prone to fracturing, it becomes weaker, it becomes less able to respond to physical stresses. So you have slower bone formation, accelerated bone resorption, so you are decoupled. Normally, you have a good balance between formation and resorption, and that's needed. Throughout the day, you're chewing up and getting rid of bad bone or bone that's been damaged in some way, shape, or form. Perhaps there's a misfolded protein. Perhaps your body sends altered DNA. Maybe there's a virus in there. Who knows? Whatever the reason is, maybe there's a little microscopic fracture. The body will sense this, send in a bone multicellular unit, which we're going to talk about, chew up the bad bone and build back the good bone. And that's your normal coupling between the osteoblasts, which make bone, and the osteoclasts that take away bone. In osteoporosis or in an estrogen deficient state, you are uncoupled. So there's more osteoclastic activity, so more bone is removed, and there's less osteoblastic activity, so less bone is formed. Up to 10% of your total bone mass is lost in the first 5 years post-menopause, which is massive. And therefore, you're at increased fracture risk. And just so you know, there's on average over age groups, a 50% mortality rate after hip fracture, meaning 1 in 2 people will die within 1 year after having a hip fracture. So not taking care of your bone health is really not smart. It is mandatory if you want to survive and have optimal aging. HRT reduces the risk of hip fracture by about 33%, which is really good. So it's something to really talk about with your OBGYN, your endocrinologist, your orthopedic surgeon, because you don't need this accelerated bone resorption as you're in menopause and beyond. It is so important to maintain your bone health. So the rates of hip fracture will double every 5 to 6 years after the age of 50. 1.5 women, or 1.5 per 100 women could get a hip fracture after the age of 50, and that increases with age to the point where that wasn't 1 to 20, it should be 1 to 2. 1 out of 2 90-year-olds will get a hip fracture, okay? So if your goal is live to 100, after the age of 90, you have about a 50-50 chance, right? Because if half of 90-year-olds are going to get a hip fracture and then half of them are going to die in a year, I guess that's 25% chance. Those aren't good odds. So maintaining your bone health is absolutely mandatory for optimal aging, aging gracefully, aging functionally. So for an average 65-year-old woman, my opinion, based on my research and my understanding of the literature, a hip fracture is significantly more likely to be fatal within 1 year than a diagnosis of breast cancer. One of the reasons a lot of women don't do HRT, or a lot of doctors stop prescribing HRT, which is hormone replacement therapy, is because of the increased risk of breast cancer incidence, okay? And that was coming from the WHI, or the Women's Health Initiative, not World's. Women's Health Initiative study, which is actually an American study, not a world study. In 2002, which we'll talk about, a lot of findings from the study were amplified and blown up, later found to be not as accurate as thought to be in 2002. Anyway, there was a big fear of breast cancer being caused by HRT, so people stopped taking it. But if you look at the numbers, having a hip fracture is a much higher risk of death. The general rates of breast cancer on no hormone therapy is about 1 in 28 women, and the overall 5-year survival of breast cancer is 91%. So getting it is only 1 in 28. The survival rates are 91% versus hip fractures where the survival rate is less than half in 1 year. So you really don't want the diagnosis of a hip fracture, in my opinion. One way to prevent that is to keep your bones strong. Now, the best way to keep your bones strong is lifting weights and being strong yourself. But another way is to make sure that you have enough estrogen in your menopausal state to help your bone maintain its integrity. So this is a conversation, again, you should have with your GYN. Again, just to emphasize that the mortality risk in a 55-year-old woman with a hip fracture is about 15 to 30% or 36% in the first year. So that's young. A 55-year-old woman getting a hip fracture, up to 40% will die in the first year. Why? Because of surgical complications, infection, just laying around in bed sore, things like that. Like all of the random things that happen after surgery. And then age 65 to 69, there's a 5-fold risk of death from hip fracture. If you're 80 and you're in awesome, amazing health, and you get a hip fracture, you still have a 3 times higher chance of dying in a year than an 80-year-old in excellent health without a hip fracture. So hip fractures are no joke. We should not get them. We should do everything we can to prevent them. So estrogen regulates the turnover in bone. We already talked about that. It inhibits the resorption from the osteoclasts, and it promotes the formation by the osteoblasts. So because it regulates the turnover in a beneficial fashion, it will maintain the density or the strength of your bone. You also have reduced levels of IL-1 and IL-6, interleukin-1 and interleukin-6. These are pro-inflammatory cytokines that turn on osteoclasts. So they induce more bone resorption. This is the inflammation we talked about, how estrogen helps keep your inflammation levels low. So you're going to regulate your turnover to your benefit with estrogen. You're going to have less inflammation in bone tissue with estrogen. The receptors on the osteoclasts will not be hit so hard, so it inhibits their function. The receptors on the osteoblasts will be hit hard with the estrogen, so it upregulates their function. And what does this all mean? At the end of the day, you have reduced risk of fracture. So bone remodeling happens with something called the basic multicellular unit, or the BMU. Each of these units or groups of cells lasts about 6 to 9 months. And inside of each unit, the components last shorter time. So the whole BMU will last about 6 to 9 months, but all of the cells inside have a lifespan of about 2 to 3 weeks. What are those? The osteoclasts and the osteoblasts. So they kind of go through the bone, chewing up bad bone, laying down good bone, and they leave behind osteocytes, which are then surrounded by the extracellular matrix, which is then having calcium deposited and other minerals like magnesium and making the bone dense and strong. So these things go through, they basically are just remodeling and revising tissue to make it stronger and better, and they're leaving behind the bone forming cells. So that's about a 1 to 10,000 ratio in cells. And the osteocytes just sit there, and they're like sensory organs almost. They're like in a sense and tell when the bone has microscopic fracturing or cracks or some other kind of damage, deposit of toxin, whatever. And they're going to signal to the body, please send us another BMU. The BMU will come through and do the same thing. So we are constantly turning over bone, constantly remodeling. Interestingly, bone is the only tissue in your body that heals without scar. So this is a very perfect system that will take away bad bone and lay down good bone that is exactly identical to the good bone that was there before it got damaged. If you're estrogen or androgen deficient, you will have more activity of these units, but they're going to be unbalanced and they're going to be uncoordinated, and they're just going to end up taking away too much bone, not laying down enough good bone, and not leaving behind enough osteocytes. And this is just because the osteoclastic activity ratio relative to osteoblasts is elevated. So you have your opening zone, your reversal zone, and your closing zone. The opening zone is the cutting cone of the BMU. That's your osteoclast. The reversal zone is the osteoblasts and other reversal cells that reverse the activity of the osteoclast, so they lay down bone. And then the closing zone is the osteocytes. This is when you leave behind the sentinel to make sure everything's okay. These all follow a neurovascular bundle. So they're following nerve and blood vessel, which has to form first, of course. They're following the nerve and vascular tissues, and then basically creating bone behind themselves. Highly, highly dependent on signaling molecules, of which one of the most important ones would be estrogen. So what about the brain? Remember I told you it's very important in the brain? So not only is bone health important to brain health, but estrogen itself is important to brain health. So there are estrogen receptors found throughout the brain very densely, and women's brains have more of these than men's brains, and men's brains have more testosterone receptors than women's brain. Okay, so that's important in how things play out in terms of physiology and biology. So estrogen inside of the brain will support your synaptic connectivity, meaning how the neurons connect to each other and create memories, for instance, or create pathways for movement, things like that. Supports synaptic development or the creation of these connections between neurons. It protects against neurodegeneration. So estrogen is important for protecting against neurodegeneration and also neuroinflammation. So therefore enhances cognitive function. There's a direct connection between bone and brain, which we talked about before, and this is linked to proteins like osteocalcin and brain-derived neurotrophic factor. Poor bone quality is linked to cognitive decline. So if you are able to maintain a functionally a functionally strong skeletal system, which includes your muscle, by the way, then you're probably going to also be maintaining a good, strong brain. So all of this kind of goes together, and estrogen deficiency dramatically affects all of it at the same time. So women show signs of Alzheimer's disease on brain scanning when menopause starts, meaning that they show signs of that tau protein, the amyloid deposits we hear about in Alzheimer's. Those show up in menopause relative to the brains of men. Okay, and this has only been found out recently with some work through a Dr. Mosconi and her group at Weill at Cornell. They did PET scans of estrogen receptor molecules that were marked, and then they were able to scan it in the brain. So relative to male brains at the same age, let's say 51, women will show more signs of the precursors of Alzheimer's. It doesn't mean they're all going to get it, of course. They just have the signs of this amyloid protein being deposited. And just so you know, women develop Alzheimer's at a rate of 2 women for every 1 man, or a 2 to 3 ratio. So 60% of Alzheimer's cases are female. And now we're starting to maybe understand some of the reasons for this. E2, or 17-beta estradiol, has many neurologic functions to include improving blood flow in the brain, helping the bioenergetics of the brain, or the mitochondrial function to produce energy in the brain. Remember, 20% of your daily glucose intake is used just by the brain. Estrogen reduces the inflammation in the brain, like we talked about, and it helps control and regulate the oxidative processes. What are those? Oxidation is when we make energy using oxygen, so the oxidative phosphorylation, or the electron transport chain. Well, one of the byproducts are free radicals or oxidative stress, and estrogen can help to modify that. So there's a higher receptor density for estrogen with menopause, interestingly. So you would think the opposite, right? You would think menopause, the receptor density goes down. Well, actually, it goes up because the brain is screaming and crying for more estrogen. So one way the body can get more of what it needs is by throwing up more receptors on the cell surface to try to capture more of any given molecule that it needs or wants. So you're going to have higher receptor density for estrogen in your brain until about the mid-60s, based on the scanning studies that are being done now. And again, this is all new data. We weren't able to do this until the technology with the imaging got good enough. So they put a tracer that binds to the estrogen receptors, and the PET scanner will pick that up and show you. This graphic shows you the before menopause estrogen density on the left, and then after. And the brighter the color, the brighter white, the more dense. So you basically, in an estrogen deficient state, your brain is just crying and screaming for more estrogen. And you would have to wonder, why don't we give it to our brains? Why are we so worried? Maybe the window for estrogen therapy is a little bit wider and bigger than we thought, and something we should consider more than we've been considering since that 2002 study. So again, synaptic and dendritic remodeling, more glial activation. The glial cells are the support cells in the brain. So that's like, when you go to war, there's the soldiers, but there's about a 10-to-1 ratio of soldiers to the support team behind them, the mechanics, the cooks, the people that build the roads, et cetera, et cetera. So the glial cells are hugely important for brain function. They're more activated the more estrogen you have. And then you have reduced generation of beta amyloid peptides or proteins if you are not estrogen deficient. Now, if a woman was found to already have Alzheimer's disease, they have yet not found a benefit for giving that woman estrogen, just so you know. So it is not a treatment for Alzheimer's, but there are some connections that are being currently studied. Now, think of all the symptoms of menopause that we talked about before. Hot flashes, night sweats, insomnia, depression, anxiety, brain fog, memory lapses. All of those are neurogenic symptoms, or brain and nervous system symptoms, okay? So if you can help the brain in an estrogen deficient state, a lot of these will go away. Male brains seem to have more testosterone receptor activity, as we discussed. more aromatase activity also. And then female brains have more estrogen receptor activity. So again, you can have as much estrogen as you want, but if you don't have the right receptor density, it's irrelevant. Conversely, you may not have enough estrogen, but if you throw up more receptors, any given amount of estrogen can give you the results you want. So your body's constantly fine-tuning production and receptor activity. So how many keys do you need? How many locks do you need? Your body's always going to be messing with this. But at a certain point after menopause, you are unable to make enough estrogen anymore. Remember, humans didn't really ever live this long. This is not how we evolved. We did not evolve to live to our 80s and 90s to 100s. Although some will say that, look at Ben Franklin and that crew, they lived to their 80s and 90s with very good cognitive function. But generally speaking, the reproductive time period is set to propagate the species. We shut off, and then, the species was not meant to survive past reproduction. So this is all uncharted territory, and we're just learning more and more, and much research is ongoing. So sarcopenia, let's talk about muscle now, which is one of my favorite subjects for optimal aging and good health as we get older and feeling good and performing well. Sarcopenia is effectively missing bone or missing muscle, or a deficiency of muscle. Normal loss of muscle mass each year after the age of 40 is 1 to 3%, which is huge. Okay, now think about compounding interest. It's compounding the wrong way. This rate is accelerated once you hit menopause, and significant muscle loss to the point of sarcopenia will happen in about 30% of those over 60. So 1 in 3 people over 60 are sarcopenic. That means they've lost so much muscle that they now have a medical definition of it. There's induced apoptosis of muscle fibers, meaning like some scheduled cell death of muscle fibers. And then you'll find that you have slower and worse recovery from any given workout, slower and worse recovery from any given injury. Okay. And it is harder to induce protein synthesis as we get older, particularly in an estrogen deficient state. So they found recently, or relatively recently, alpha and beta estrogen receptors in skeletal muscle. Go figure. Again, previously thought estrogen had no effect on muscle. What are you talking about? Only testosterone. Turns out there are estrogen receptors in muscle, and it will affect satellite cell function. Satellite cells kind of hang out in the periphery of muscle and are there and ready to turn into muscle forming cells. They're effectively stem cells. So they're involved in repair and growth of a muscle. And these are upregulated or enhanced by estrogen. Estrogen deficiency does the opposite. Estrogen is linked to the integrity of the mitochondrial function of the skeletal muscle. From prior talks, you know that the mitochondria is the engine of the cell. So nothing works if your mitochondria doesn't work well. And then you're going to have reduced oxidative stress in the muscle if you're not estrogen deficient. If you are estrogen deficient, you will have more oxidative stress in your muscle. The receptors act as transcription factors. What does that mean? When the lock has the key come in and it turns on, it's going to send a signal to the nucleus of the cell. Certain genes will be turned on or off. So the estrogen receptors in the muscle cells influence genetic expression at the muscle level, at the nuclear level, and induce more muscle protein synthesis and collagen synthesis, all enhanced by estrogen. Remember, collagen is just another form of protein. Muscle's a form of protein, collagen's a protein. It's just a different type with different molecules linked together in a different way. But at the end of the day, estrogen helps both of them become better. So you can maintain and increase your muscle mass and strength with estrogen, believe it or not. Can enhance your protein synthesis. Now, protein is involved in everything. Bone is a protein. A lot of your nervous system is protein. GLP-1s are protein, insulin's a protein. All of these are protein molecules. So protein is not just muscle. Skin, collagen in your skin. So you're going to have enhanced protein synthesis with estrogen. Enhanced satellite cell proliferation we talked about. So more muscle forming stem cells. Your recovery from any given insult to your muscle system will be quicker and faster and better. You're going to have less of this programmed cell death, otherwise called apoptosis. And if you're estrogen deficient, the normal age-related sarcopenia that we see is going to be amplified, enhanced, and go faster. So again, one of the things that make us not age well or become frail is sarcopenia. One of the best ways to not be sarcopenic is to exercise and lift heavy things, which you need to do, but also to reconsider your estrogen deficient state. So what about joints and cartilage? Remember I told you 80% of women have achy joints and pain and stiffness and whatnot? We know that as osteoarthritis progresses, there's more and more cartilage breakdown and more inflammation inside of the joint. It is a whole joint disease, and it is an inflammatory process. There is joint pain in 70 to 80% of menopausal women, and we know there's an increased risk of any given inflammatory orthopedic condition. So menopausal women will have carpal tunnel syndrome. Menopausal women will have frozen shoulder. Menopausal women will get trigger fingers. All of these are inflammatory orthopedic conditions because the inflammation is affecting the connective tissues, thickening them, reducing the elasticity, making them dysfunctional. And you get all of these problems. A lot of it linked to estrogen deficiency. So articular tissue, articular meaning joint, has long thought to be unresponsive to estrogen. Again, for decades, if not hundreds of years in medicine, it was thought that estrogen had nothing to do with your joints. What are you talking about? Now we know that's not true. We've learned differently. There are multiple levels of activity involving estrogen receptors, along with your other anabolic steroids like testosterone, in the joint tissue, all the way down to the genetic level, or what affects nuclear function. So again, remember what I told you in the beginning, women on aromatase inhibitors tend to feel really, really crappy in terms of body pain. And that's because their estrogen receptors are turned off and the aromatase activity is turned down. So when the aromatase activity is turned down in a particular tissue, you have less of that estrogen key to lock into the lock. And so all of the functionality in the articular tissue is diminished and you have more pain. Remember I told you it's involved in chondrogenesis, or making of cartilage, integrity of the collagen and the elasticity of the tissue, reducing stiffness. The collagen protein itself is diminished in terms of production and function. So yeah, there is a lot of important things that estrogen is doing in your cartilage. And a lot of that has to do with not just the receptors, but also the aromatase activity that is found in the tissues itself. This slide is very busy and annoying, I'm sure, but I just put it up here to show you how important estrogen and androgen receptors are in terms of function of bone, collagen, connective tissue. So chondrocytes, periosteal cells, that's the skin on the bone, osteoprogenitors, meaning bone-forming stem cells, osteoclasts, osteoblasts, osteoprogenitors like that will stimulate more periosteal growth. All of these are affected by estrogen, and just a few are affected by some of the androgens. So it's massively important in your connective tissue system, and I don't think we can emphasize it enough. Being estrogen deficient will make your musculoskeletal system not work quite as well as you want it to. So osteoarthritis is associated with estrogen deficiency. This is why we start to see all of the symptoms bloom at that magic age of 50, 51, right? When women hit menopause. It's going to damage your cartilage, your subchondral bone. That's the little thin, hard plate of bone that sits just under cartilage to allow cartilage to function with its shear reducing, shear reducing activities that allow joints to move. You don't have good cartilage if you don't have a good subchondral plate. And a lot of osteoarthritis symptoms are from that subchondral plate breaking and having cysts form. We've already talked about how important it is for muscle function. We didn't talk about the synovium, which is the water balloon around every joint. It has a lining, so that's your joint capsule. And the inside of that capsule is lined with what's called synovium, and that kind of regulates the joint fluid. And if the synovium gets inflamed or irritated, that's a sign of osteoarthritis, or one of the symptoms of. So it affects even that. And then, of course, the ligaments. Ligaments are the connective tissue bands that connect bone to bone. Tendons are the connective tissue bands that connect muscle to bone. That's the difference between ligaments and tendons. So if you're estrogen deficient, you are way more likely to have osteoarthritis. Now, there's really not a lot of literature out there on estrogen and connective tissue in terms of tendon and ligament. way more on bone, way more on muscle, a lot more on brain starting. So there is some conflicting information out there. We think, though, that in general, less estrogen causes more stiffness, more inflammation, therefore more pain and more destruction of tissue, decreased collagen synthesis, because of course that's proteins. We know there's decreased protein synthesis, and then decreased elasticity or give. And then also, if you have less elasticity of your collagen bundles, you're not able to store energy for later movements as effectively. So that changes your bioenergetics. The receptor, the estrogen receptor on tendons, was actually found as far back as 1996. That's when it was characterized and described. So we've been knowing that tendons and ligaments have estrogen receptors. It's just nobody's really looked into it too deeply. Hopefully, more and more studies are going to be done because it does dramatically affect things like ACL tear rates. Now, Plinius the Elder in 77, the year 77 of the Common Era, wrote about the silphium plant extracts being rubbed on people with tendon pain, and that is a phytoestrogen. So that extract was meant to reproduce the effects of estrogen on tendons and ligaments and made people feel better. Now, did he know that? Probably not. But all he knew was that plant worked. But we now know that it is a phytoestrogen found in that extract that is the active ingredient. So again, it decreases the stiffness of tendons, estrogen does in ligaments, and this has direct effects on performance and injury rates in women. So, most women, when they're athletic, are athletic in their younger years. Not saying that anybody out there is not a pickleball champion right now, but what we found is women seem to tear their ACLs at a much higher rate than men. And for years, it was thought it can't be hormones. It's not hormones. What are you talking about? But now more and more literature is coming out showing that hormones do directly affect the integrity of the ligaments, the ACL, and also how they respond to injury, how they respond to stress, and how they respond to sudden changes in length and position as would occur in an injury, let's say on a soccer field. So while the estrogen is decreasing the stiffness of the ligaments and tendons and their ability to respond and heal with insult, at the same time, estrogen is increasing your muscle mass and power. Remember, I told you it induces more muscle, protein synthesis, etc. That combination, if you've got more strong muscle and weaker, less tissue or connective tissue, can lead to ligament and tendon tears. This is why you see people like powerlifters or athletes that are known to take anabolic steroids, they tend to rip their tendons and ligaments more than others because their muscles are so much stronger than the tendons and the ligaments, because a relative change in the tissues with any given hormone load ends up being not good if you're at that level of athleticism. Obviously, this isn't going to happen to me, but like a high level, let's say football player who happens to be illegally taking some of these things, like anabolic steroids, can have mass, ACL tears and Achilles tendon ruptures because the muscles are just so strong. But anyway, this just shows you how estrogen and progesterone change in the day of the menstrual cycle. And we're now starting to correlate ACL tears in female athletes to this chart. In women that take hormone or contraceptive pills in the college range seem to have fewer ACL tears. That's all being looked at right now, and hopefully there will be some sort of way to prevent the major number of ACL tears in female athletes going forward. But until recently, it's kind of been poo-pooed and ignored. We have questions already. Okay.
If synovial fluid is cloudy or straw-colored, is that from inflammation?
The question is, if synovial fluid is cloudy or straw-colored, is that from inflammation? I have drained a lot of knees in my time, and usually you're only draining a knee if it's swollen and uncomfortable to somebody and big enough that you would even want to drain it. Generally, it's kind of always straw-colored, but a little bit clear. So because we know that osteoarthritis is inflammatory, and the only time you're draining a knee and getting synovial fluid out is when there is symptomatic osteoarthritis or some type of injury intra-articular, then yes, it would be related to inflammation. I don't think I've ever drained a non-inflamed knee to tell you if I've actually seen the difference, but I would say it's highly correlated to inflammation, yes.
Deborah, Which of your products will support increasing estrogen?
Deborah wants to know which of my products. So she's talking about the Well Theory products, because that's a line of like supplements and natural medicine that I have, that I formulated and curated. She wants to know what will support estrogen. So we don't have a product that is specifically designed to upregulate or downregulate hormone production. A lot of that, you have to take peptides that induce activity of the pituitary gland and or the adrenals and whatnot, assuming your ovaries aren't functioning. But what we do have are the supplements that ameliorate the effects of estrogen, or estrogen deficiency rather. So remember, I told you it increases inflammation and oxidative stress. So I focus more on that, on reducing inflammation, reducing oxidative stress. Sometimes, and I'm going to talk about the natural substances you can take that increase theoretically the estrogen effects, but my supplements work on inflammation. So you're going to reduce the inflammation, reduce on oxidative stress levels, and also can help a lot of the brain fog and cognitive effects. So for instance, the energy supplement and the brain and the focus supplement have a lot of mushroom-derived beta-glycans that are nootropic and induce, in the basic science literatures and preclinical studies, help brain functionality in terms of glial cells, glial support cell function, reducing brain inflammation, and then enhancing nootropic activities. And then, of course, the omega-3s. Omega-3s should not be de-emphasized. These are amazingly wonderful substances found in nature that dramatically reduce brain inflammation and help the cell membranes in the brain form better. So that helps too. And then K2, which we'll talk about briefly later. The K2 supplement we have can help counteract both the bone lack of mineralization and then the increased mineralization of arteries that happens in the post-menopause and perimenopausal stage. So K2 is actually used in Japan to treat osteoporosis, not here yet. But K2 is hugely important for your bone health. And at the same time, it's also beneficial for your cardiovascular system. But exercise is your number one weapon for all of this. Next slide.
Deb, she
Hold on.
she had a total hysterectomy in her late 40s, and she really thinks it had a big impact on her bone and joints, and all the doctors brush her off. She's 68, maybe too late, severe pain and stiffness. He has her on methotrexate. I guess she just wants a little.
Okay. My producer just.
They can see it.
Okay, they can see it good because I could barely hear her read that to me. That was kind of a long question from someone, and it was about having a surgically induced estrogen deficient state in your 40s and you never replenished. I'm assuming as a total hysterectomy. I think that's what you said, which means the ovaries were taken too. No hormone replacement therapy. Now this person's 68 and they just feel terrible. And I guess from the age of 40 to 68, so for 28 years, no physician has offered or agreed with hormone replacement therapy. And that's sad, but that is the time frame during which the Women's Health Initiative, all of those scare mongering was happening. And most doctors were trained not to ever offer it and to definitely not give it because of the purported breast cancer risks. 68, most people would say now probably the window is closed, but unless you do like topicals. So you need to go talk to your GYN about potentially some topical estrogen only. And these are all FDA approved medications. You don't have to get pellets or go to some fancy dancy, very expensive off-label clinic. You can get FDA approved topicals that have very few side effects and very low risk profiles to help offset some of these problems, even at the age of 68. So you just need to go find a GYN that's thinking about these things, or a primary care, or an endocrinologist. 68's pushing the window of opportunity, but again, with the low dose topicals, I don't think it's out of the realm of possibility to help you. But of course, I'm not allowed to offer medical advice. This is for entertainment and educational purposes only. Okay, what are the collective systems in the musculoskeletal system from estrogen deficiency? Just to remind you, you probably already know this because you probably already feel it. Arthralgia or joint pain. sarcopenia or loss of muscle and weakness, osteoporosis or weak bones, tendon injuries, ligament injuries, and then add to that all of your neurologic symptoms. 70–80% of you out there with menopause are going to have these symptoms. 25% of you will be fully disabled by these symptoms, meaning that they're just going to wreck your life and you will have no quality of life. I cannot tell you enough how lifestyle choices are going to make all of this worse. If you eat crappy food, you're not taking the right supplements, you're not getting sleep, and God forbid you don't exercise, and God forbid you smoke, then forget about treating this with hormone replacement therapy. It's irrelevant. You have to fix your lifestyle first. That is by far the most important tool you have. Diet, exercise, mindset, sleep, or mindset, exercise, diet, sleep, the meds protocol, as in the book I wrote, Bone on Bone. I go into it in detail. Pick up a copy. It'll kind of give you a guidebook on how to have a better lifestyle. It will treat all of this more than any medication I could name. Hormone replacement therapy, let's talk about it. Replacement therapy implies that there is a loss of something or a deficiency of something. So, and that's the medical definition. We never replace something that is at a normal level. Menopause is, by definition, estrogen deficiency. Therefore, you can treat it with hormone replacement therapy. There are many ways to replace hormones, many ways to apply it, many doses, many combinations, okay? Generally, the indication for hormone replacement therapy is if you are symptomatic for menopause, which generally means hot flashes. Optimal health is never considered to be an indication for treatment in modern American medicine. So if you go to the doctor and say, I want to be as healthy as I can be and I want the best health, and I know for my brain and my muscle and my bone, I need to be on hormones, they're going to laugh at you. So just know that right ahead. Most of them will, I should say. So don't go asking for hormone replacement therapy because you want to optimize your health. The only FDA approved indication is for hot flashes. And even then it's very few medications. But again, this doesn't mean I want to direct you to some random, anti-aging clinic where you're going to be overdosed with hormones. Just sit down and have a really good conversation with your primary care, your GYN or your ortho, and say, these are my problems. This is my goals. This is what I want. And really you should have your own personal risk profile done and then make decisions based on that. Because again, the best medicine is precision medicine. Although insurance, government, FDA, everything is population-based medicine, but really good medicine is precision and person by person. So the Women's Health Initiative, this is the elephant in the room. It was launched in 1993 to 1998 timeframe. The largest randomized trial on postmenopausal women ever. And in fact, it's still ongoing. My mother was in one of these original people, and she's still in it and still has surveys done. So they got people in generally the age group 50 to 79, okay? And then there were arms of the study. So one arm, they looked at women, and this is the part of the Women's Health Initiative that was looking at hormone health. There are other parts. But the one arm was combined hormone replacement therapy, which was a equine synthetic estrogen with a progesterone. One was estrogen only, again, an equine synthetic estrogen. And then the last group was placebo or no hormone replacement therapy. And they just followed these women. So the drug they gave was 0.65 milligrams of a conjugated equine, meaning horse, estrogen, with 2.5 milligrams of medroxyprogesterone. The average age of the participants in this study when it started were 63. Most of these women were 12 years past menopause when the study started. So they had already been without hormone replacement therapy for 12 years. They entered the study. One group gets both hormones, one group gets just the estrogen, and one group gets nothing. When these results came out, there was no discussion of relative versus absolute risk regarding the breast cancer risk. So the relative risk was publicized and promoted in 2002. The relative risk increase for breast cancer in these groups with the combo therapy was 26%. So it sounds horrible and terrible. Therefore, prescriptions for Premarin plummeted. Before this, Premarin was the most prescribed. The absolute risk was actually 0.008%. There were 8 more cases for every 10,000 women that would get breast cancer from these therapies. So that is why it is important when you get these information, when you see data from medicine written in the normal press or the media or on Facebook or whatever nowadays, you have to go find the study and see, are they talking about relative risk or are they talking about absolute risk? Because that is a huge difference. So in other words, you could say a 10% increased risk if it's 1 in 100, I'm sorry, 1 in 10, but 1 in 10 doesn't sound as bad as 10%. So it's just how you spin things, I guess. So make sure you understand how the data is spun. In this case, the relative risk was 26%, but the absolute risk was 0.008, not 0.0008. So fewer women take hormone replacement therapy now. So more women are estrogen deficient. More women have all of those neurologic symptoms that we talked about. And more women have hip fractures, which means that more women are dying from hip fractures. And more women have a terrible quality of life, all because of a little spin of the results of the Women's Health Initiative. We'll have to correct that on the slides. So the study was stopped early, this aspect of the study, looking at this with those 3 arms of hormone replacement therapy. What they were actually trying to figure out was, is there really a cardiovascular benefit to taking these things, okay? Because that was what all the doctors before 2002 thought, which turns out later probably still is true. But anyway, the study was stopped early in 2002 because of this increased relative risk of breast cancer that was heavily advertised. And the hazard ratio is 1.24. They also thought there was a higher stroke risk, a higher cardiovascular disease risk, higher pulmonary embolism risk, and that there was no overall benefit found to taking hormone replacement therapy for the women in this study. Therefore, they felt that the risks outweighed the benefits to the degree that they shut the study down in 2002. And that's what started all of this controversy about hormone replacement therapy. So again, the breast cancer risk was found to be 26%. But again, that was combined therapy with an equine conjugated estrogen and medroxyprogesterone. And it was a 26% relative risk, not absolute risk. Meanwhile, the colorectal cancer risk was found to be 38% decreased. So there was less colon cancer risk, more breast cancer risk. The colon cancer, when they did find it, they felt that the cases were more advanced, so like a higher stage. The other thing that they didn't really advertise when they advertised this in 2002 was that this study group was older women, remember average age is 63, and also they were asymptomatic. So these were asymptomatic older women about 12 years out from menopause that didn't really have all of the vasomotor symptoms, and they gave them a conjugated estrogen with progesterone and then studied them, and really the best they could find was a 26% relative increased risk of breast cancer. But they didn't even talk about the mortality or the treatment or the stage or anything like that about that. They just shut the study down, advertised it, and worldwide, prescriptions for hormone replacement therapy just fell off, like just basically disappeared. And so now you're left with a planet of estrogen deficient women. The data has been so confusing, it's confusing to me to try to tease out because they're still writing studies from the data set of that 1993 to 2002 cohort, okay? They're still looking back at it and doing meta-analyses of multiple studies. There's a group in Finland, there's a group in Netherlands, there's a group in Europe, and they're still trying to figure out what was going on with this data, and they're starting to look at newer and bigger groups of women to try to figure out, can we give women hormone replacement or can we not? So I just found one random example from 2015. There was results that were released at I want to say the American Reproductive Association meeting in Baltimore, okay? And they said that today's research followed 80 women on hormone replacement therapy for more than a decade and found the treatment caused no increased risk of breast cancer, no increased risk of heart disease, no increased risk of type 2 diabetes, okay? So that got publicized and amplified by the press. That is a headline on the top. It's official. Hormone replacement therapy is not a danger to women, as experts conclusively dismiss worries over safety. Well, then the same time in the press in Europe, you get this little chart and this statement down here on the bottom from Cancer Research in the UK. The overwhelming body of evidence, including the results of the Million Women study, show women who are using combined hormone therapy double their risk of breast cancer compared to those who don't. So this is the same year on the same study that was released at some meeting in Baltimore. It's just so confusing what is going on. And that little chart under there on the risks, 2 more women get breast cancer if they start taking hormone replacement therapy at age 50 for 5 years. And 1 more woman out of that group of 1,000 women gets ovarian cancer. It's a doubled risk, but it's 2 out of 1,000 versus 1 out of 1,000. So I can understand why you're confused. Most physicians are confused about this too. So more on the Women's Health Initiative. So the estrogen-only arm, 2004, they released some results. No increased breast cancer risk. Decreased breast cancer risk actually was found. Fewer hip fractures, obviously. Neutral cardiovascular disease risk, they felt, but they stopped it due to a stroke risk, they said, but the overall safety profile was found to be fine. Confused? I'm confused too. Most participants, again, were already 10 years post-menopause when they started in these studies. And again, a synthetic equine-based hormone was used. We have better formulations now. After the media scare from the 2002 presser that they did out of the WHI, there was an 80% drop in hormone replacement therapy use. Prior to that, Premarin was the #1 prescription up to that point. So women before 2002 were not estrogen deficient. They were happy. They had better quality of life, fewer hip fractures, et cetera, et cetera. Then this came out, 80% drop, and now we're dealing with the aftermath of it still. So when they went back, they meaning another group, and these are multiple studies, a study timeline. I'm just going to blow through this quickly for you. So 2007, they found that if you were younger when you started hormone replacement therapy, you did have cardiovascular benefits. So if you were less than 60 or less than 10 years outside of menopause when you started, it did help your cardiovascular system. In 2008, they released a meta-analysis or a study that showed that your breast cancer risk was not elevated during the first 7 years of use of hormone replacement therapy. And then they found that, generally speaking, there are good benefits of hormone replacement therapy if you start it early relative to when you hit menopause. 2011 study out of a Danish group out of the Netherlands, early hormone replacement therapy reduces cardiovascular disease deaths, echoing that 2007 data. 2012 from the Women's Health Initiative, estrogen only, meaning not the combo therapy, decreased breast cancer risk long-term. 2013 showed that HRT reduced all-cause death. So dying from any reason under the sun is reduced if you start hormone replacement therapy earlier. 2017, an 18-year follow-up study from the WHI, no increased death rates with hormone replacement therapy. What does that mean? Even if you get a breast cancer diagnosis, the death rate is not going up. 2019, another meta-analysis confirms safety. 2020 found that breast cancer trends, or breast cancer, I guess, incidence is trending down or declining post-2002 paper. This is thought to be due to less hormone replacement therapy. So this is a different study looking at it a little bit differently, saying that the rates of breast cancer have gone down. They think because there's less hormone replacement therapy being taken. That's a 2020 paper that came out looking at the 2002 data. So again, very confusing all over the place. But seems to be most of the later studies are showing that it is beneficial. 2022, the guidelines there are guidelines saying that hormone replacement therapy is safe and beneficial for those under 60 or those less than 10 years out from menopause when you start. 2023 found that the micronized progesterone formulations, which is different than the medroxyprogesterone given in the WHI, lowers the breast cancer risk, okay? So micronized progesterone combined with a different formulation of estrogen or estradiol is a completely different medication than what they were given in the Women's Health Initiative. In 2024, it was shown that hormone replacement therapy reduces fractures, which is what I care about as an orthopedic surgeon, and hormone replacement therapy improved quality of life, which is what I care about as somebody that's very interested in wellness and just holistic health. This figure shows you that estrogen only taken early, again, less than 60, less than 10 years out from menopause, gives some protection from Alzheimer's disease. Estrogen taken with progesterone orally does the same thing. Estrogen taken later is neutral. Estrogen with progesterone taken later actually has a very small increase in risk. So what does this mean? The timing matters. That 2002 presser and media uproar did not mention anything about the timing of what was given or the formulations of what was given. So that data should be looked at very skeptically. And I think more of the newer, more nuanced studies are better information for you. So cardiovascular disease and hormone replacement therapy. This is one of the reasons doctors in the 90s were giving this out, to reduce cardiovascular disease in women. It's still the #1 killer in women, by the way, #1 killer globally. So if you start hormone replacement therapy early enough, you will have less atherosclerosis. Remember, I told you K2 can help with this as well. Well, lack of vitamin K or K2 will cause calcium deposition in the plaques in your arteries and harden them, and you'll have stiffer arteries. What does a stiff artery mean? More prone to high blood pressure, et cetera. K2 can really help reduce atherosclerosis and the sequela of atherosclerosis, and also can help your bone mineralize properly. So K2 is a supplement we have that will ameliorate the symptoms of estrogen deficiency. Again, I don't really have a hormone per se. So reduce atherosclerosis if it starts early. In the reanalysis or the look back at the data of the WHI, no increased risk of cardiovascular disease if hormone replacement therapy is started early enough, and actually potentially beneficial. Also reduces the risk of getting diabetes because it improves insulin sensitivity. So you're going to help the endothelial cells that are lining the vessels. You're going to reduce the deposition of plaque and calcification of that plaque. You're going to reduce inflammation in the cardiovascular system, and you're going to reduce oxidative stress. So overall, estrogen deficiency makes your cardiovascular system worse, and having a good estrogen level helps it. Now, that is not to say that taking estrogen is a way to prevent a cardiovascular event. In other words, it's not meant to be taken as a primary prevention drug like a statin is, okay? There is an increased risk of blood clotting, which means an increased risk of stroke. So a lot of women on hormone replacement therapy, for instance, when they go have certain types of surgeries, have to be on a blood thinner after surgery to help reduce that blood clot risk. So again, this is one of these conversations you have to have with your treating physician. You don't want to take this to prevent a cardiovascular disease knowing that there's a risk of increasing blood clotting. It's a nuanced, balanced thing that you have to look at. But overall, if you start hormone replacement therapy younger or within a certain time frame after menopause, you will have fewer cardiovascular disease events. So the current research is supporting hormone replacement therapy as having different effects on younger women than on older women. So what is a young woman in this? 50 to 59. So the vascular biology of estrogen makes the timing quite important when you start this thing. Waiting until too late is not a great idea if you're looking for cardiovascular benefits. Now, the good news is we have many other drugs that are great for the cardiovascular system that your doctor's probably already put you on, like statins or PKS9 inhibitors or whatever. You only would get prescribed a hormone replacement therapy if you're symptomatic, like if you're having the hot flashes generally is the indication. And again, you always have to combine with diet and exercise. So there is no magic bullet. You still have to eat well and you still have to exercise. Exercise is by far the best way to treat any problem under the sun that affects humans. So please remember that throughout this talk. But know that if you start hormone replacement therapy at the age range of 50 to 59 or within 10 years of menopause, you should have cardiovascular benefits. Lancet in 2019, another meta-analysis, which is all that means is they looked at a bunch of other studies and combined the data in a statistically valid manner. So they looked at the breast cancer incidence rates in groups, and then they asked, what is the additional risk of a breast cancer diagnosis if you take hormone replacement therapy? So no hormone replacement therapy in this group of women. It was 1 in 16 would get breast cancer. Remember I told you generally the rates are 1 in 28, so that's actually higher. So no hormone replacement therapy in this meta-analysis, 1 in 16 women would get a breast cancer diagnosis or incidence. Doesn't mean that they died from it. Doesn't mean that it wasn't treated successfully. They just got that diagnosis. If they started hormone replacement therapy in the 40s and 50s, if it was estrogen only, the additional risk was 1 in 200. If it was estrogen with some progesterone, the additional risk was 1 in 70. If it was estrogen and progesterone, the additional risk was 1 in 50 or 2%. So that's not the overall risk, it's the additional risk on top of the general risk of 1 in 16. So you could spin that and make that sound horrible and bad, but think about this. The risk of breast cancer from being overweight or obese is 6-fold higher. So you have to manage the underlying health and lifestyle before you start worrying about the minutia of your increased additional risk of a breast cancer diagnosis on hormone replacement therapy at the age of 40 or 50 or 59. The risk from being overweight and obesity, far greater. The risk from smoking, far greater. So lifestyle matters more than anything, but I'm saying that hormone replacement therapy is linked to some small increased additional risk per this Lancet 2019 article. So what does that mean? You have an increased risk of incidence or a diagnosis, but it doesn't mean that you're going to die from it. The mortality actually dropped overall for this 108,647 women with hormone replacement therapy, meaning all-cause mortality. So fewer women died if they were on a hormone replacement therapy, even though there was an increased risk of either 1 in 200, 1 in 70, or 1 in 50 of a breast cancer diagnosis. The mortality dropped for cardiovascular disease, which means fewer women died from that. And the mortality did not increase for breast cancer. So even though a few people were diagnosed more often with breast cancer on hormone replacement therapy, they did not die from that breast cancer at higher rates. But they did die from everything else more often if they weren't on hormone replacement therapy. And of course, in this study, they completely excluded topically applied vaginal estrogen, which has an even lower risk profile. So this is just to show you that a lot of our literature is very confusing and complicated, and you can spin the stats any way you want, as with everything else in life, as I'm sure you know. Okay, we have another question.
Is HRT synonymous to taking estrogen, or does it add other hormones as well?
Well, HRT just means hormone replacement therapy. That could be testosterone, could be progesterone, could be DHEA, it could be androsterone, like the bodybuilders take, or I can't even remember the names of the stuff those guys take, or it could be estrogen, or it could be combination therapy. HRT is just a general phrase. So the absolute risk of cancer up to the age of 70 in this study, if you started combo therapy at the age of 50 and took it for 5 to 10 years, okay, the risk of cancer for never users was 6.3%. The risk of cancer for this group, meaning combo therapy starting at age 50 for 5 years, was 8.3%. So it was an increased risk of 2% or 1 in 50. That's why I emphasized 2% earlier. So the estimated incidence of breast cancer, meaning the diagnosis of it, went up by 2% in the worst group that they found. But again, the death rates did not change. They did not go up for breast cancer. So phytoestrogens, these are supplements some people try to take instead of getting on hormone replacement therapy. So some of these are genistein and daidzein. So these are isoflavonoids that are found in soybeans and clover, okay? You can isolate out these molecules and in some cases take them or avoid them depending on your goals. And then there's things that are found in green tea or legumes like enterolactone or enterodiol. Genistein is found to inhibit steroidogenic enzymes. It inhibits the tyrosine kinase activity. That's just one particular enzyme in the pathway. And they may have some antioxidant activity. Some people believe that phytoestrogens can protect against breast cancer, prostate cancer, colon cancer, cardiovascular disease, and osteoporosis. In other words, They're acting much like hormone replacement therapy, but protecting against breast cancer. Now, I don't think there's a ton of data on this. There's not a lot of good human studies. Most of this is coming from basic science or preclinical studies. But in general, I think this is one avenue that you could go down if you're trying to replace estrogen without estrogen. That said, you should talk to your GYN or your treating physician about it before you go hot and heavy into taking a bunch of genistein. Some herbals that have some limited evidence of helping with the vasomotor or the symptoms of menopause. Black cohosh has a lot of history or press, but it's been associated with liver toxicity. If I remember correctly, I think there was a tainted batch at some point in the past, so kind of got a bad rap. But black cohosh is one. As with all supplements, you want to make sure they're third-party tested and that they're made at an FDA-registered facility. That's how ours are. You can find many brands that do that. So just make sure you're not buying the cheapest thing that comes from God knows where and it's not tested. So black cohosh has been taken for hot flashes. Dong quai, which is a traditional Chinese medicine group of herbs. Evening primrose oil. Flaxseed and omega-3s. Omega-3 is just highly anti-inflammatory and it'll reduce brain inflammation, which could potentially help the hypothalamus function better, which could reduce the fever or the hot flash inducing aspects of menopause. Maca, ginseng, red clover, vitamin E, all of these have been associated with reducing menopausal symptoms. Limited evidence, no large prospective randomized controlled trials, obviously, because nobody can patent these things. So of course they're not going to do that. But just know these are out there. Again, I focus on reducing inflammation and oxidative stress and upregulating brain function, and then the K2 for the cardiovascular benefits. And then for bone health, you're still going to need calcium and vitamin D. Remember, every osteoporotic drug on the market was studied while the participants were taking calcium and D3 at the same time. So you can never not take those as you enter into menopause and beyond. And probably you should be taking it sooner. Other medications that have been prescribed for hot flashes, antidepressants, the SSRIs and the SNRIs, the gabapentinoids like gabapentin and Lyrica, clonidine, which I think is a calcium channel blocker, Paxil, which is another antidepressant, but you can't take that if you're on tamoxifen, the selective estrogen receptor modifiers. Some medications that are being considered for hot flashes are oxybutynin, stellate ganglion blocks, so actually like putting a needle in your cervical spine and blocking nerves. And then a newer one that's out on the market is Linkuit, which is a neurokinin receptor antagonist. So that acts centrally on the hypothalamus to decrease the function of the hypothalamus that is causing the increased body temperature. And then some different forms of estrogen like E4. But all of this is just to treat hot flashes. Again, remember I told you that's the only accepted indication to treat menopause is if you have hot flashes in the medical community. But I just went through all of the benefits of estrogen and all of the detriments of being estrogen deficient. So for me, I'm concerned about people's bone health, muscle health, and connective tissue health. So to me, estrogen is hugely important for all of those, not just if they're having hot flashes. But from the larger population, insurance, and government picture, the only thing they care about is if you complain about hot flashes, and this is all you're allowed to take. And most of this is off-label. So just keep that in mind. So the International Menopause Society, yes, that exists. Their 2011 consensus statement was, the excessive conservatism engendered by the presentation to the media of the first results of the Women's Health Initiative in 2002 has disadvantaged nearly a decade of women who now it's 2 decades, who may have missed the therapeutic window to reduce their future cardiovascular, fracture, and dementia risk. Current data, all of those studies I just showed you, the newer studies and the newer analyses of the older data from the Women's Health Initiative are highly supportive for preventing or reducing fractures, cognitive dysfunction, cardiovascular disease, and mortality in women. That is hormone replacement therapy. Highly supportive of hormone replacement therapy for a better quality of life. You should probably start young, somewhere between 50 and 59, or within 10 years of hitting menopause. The type of the progesterone matters a lot, and whether or not you're taking combo therapy matters a lot. So you need to have a sit-down conversation with whoever's going to be prescribing this to you, or whoever your treating physician is, and tell them your concerns. You want to have a good quality of life. You want good bone health. You want good muscle health. You don't want cognitive decline. You don't want brain fog. You want good skin. You don't want hot flashes. You don't want anxiety. You don't want depression. What can I do? And know that the breast cancer risk, if they bring that up, ask them relative risk versus absolute risk. And is it just the diagnosis of, or is it death from? Because those things matter when you're making a decision for your health. And that's it. Sorry, there were some typos on the slides. I'll go back and correct those. Any other questions? That's a lot of information. I think in a nutshell, obviously, I'm a fan of keeping yourself not estrogen deficient. You should understand the risk of an increased diagnosis of breast cancer. You should also understand the risk of everything else, i.e. a hip fracture diagnosis, which is worse in terms of outcomes nowadays with all of the treatment capabilities we have. And then your quality of life is just going to be better if you manage your hormones better. You can be on a generic FDA covered by insurance off-label usually medication. It can be topical. It can be a suppository. It can be a pill. All of this is possible to give you a better quality of life, better bone health, better musculoskeletal system without dramatically increasing your risk of breast cancer. And you can have better cardiovascular health. This isn't to say that you want to use this instead of a statin, or you want to use this instead of this or that, but you need to think about it, and you need to talk about whoever is managing your overall hormone health.
What do you mean by absolute versus relative risk?
Absolute risk versus relative risk. What do I mean? So a relative risk is, how do I describe this? If the absolute risk is 1 in, let's say your absolute risk is 2 in 100, that's 2%. But before an intervention, the absolute risk was 1 in 100. So it went from 1 to 2. The absolute risk only changed by 1 person in 100, but the relative risk doubled. So you can make things look a lot worse if you describe the relative risk versus the absolute risk. So you went from 1 to 2, right? That's doubling your relative risk, as opposed to looking at it a risk of 1 in 100. Now it's a risk of 2 in 100.
Where can we find the slides? We don't make the slides for them, but they can find the redo, like the broadcast on the website.
Oh, we will rebroadcast this on the website. We don't generally make the slides available. I have to change these slides anyway. But you can watch the talk again on thewelltheory.com or on Warner Orthopedics.
Can you ask them to share so that more people get?
Oh, yeah, we would like you to share this to anybody that you know that might benefit from this talk so that they can learn with you. Obviously, this is going to be mostly your friends in the age group that might be entering menopause. But remember, most of these people have a family member, so you may want to send it and share it to the family members so that they know what health risks these menopausal people are facing being estrogen deficient. And that's it. Hopefully you'll have a great day, and just food for thought, if you will. Remember, diet and lifestyle matters the most, but I don't think being estrogen deficient is mandatory anymore as it was after 2002 until fairly recently. Yeah, do not be scared to bring it up to your treating physician and having a conversation if you're currently not on hormone replacement therapy and think that maybe you should be.